Hello, my name is Carlos Curtis Lopez. I'm a fourth year medical student and the Manchester rep for NANSIG. This is a two-part talk about headache and headache assessment. Part 1 will be looking at how to approach a patient with a headache, and then the main primary headaches. And then part 2 will be about identifying red flags and then some detail on some secondary headache causes.
So firstly, a bit of background about headaches. We can split the etiologies into primary and secondary headaches. The primary ones worth knowing about include tension headache, migraine, and cluster. Out of the secondary headaches, there are some important acute ones to know about, such as subarachnoid hemorrhage, and then there are more chronic ones, such as giant cell arteritis, medication overuse, or some rarer causes we'll cover at the end. So when taking a history from a patient with headache, a good thing to cover initially is Socrates, um, like you would with any patient who comes in with some sort of pain. The whole site, onset, character, etc. Will cover individually and specifically for each pathology as I talk about it later on. But what I will say for now is the associated symptoms part. Good ones to cover for headache include nausea and vomiting, either as an extra symptom in migraine or part of cluster headache or glaucoma or something like that. Visual issues, photophobia, neck stiffness or rash, systemic symptoms like fever and weight loss, any issues with sleep, any tenderness in the temporal region or neurological deficit. For the exacerbating and relieving part, you need to ask about things like is it worse on straining or coughing, leaning forward? Are there specific triggers like caffeine or something else? Essentially covering for the red flags as well. It's hugely important. Asking the patient or those around the patient about any trauma history, specifically to the head. Always ice the patient early on in the history so that you have an idea about their worries and sort of gain some insight into what the patient's thinking as well. For instance, if they've had a migraine before, they'll know better than you that if it feels like a migraine or not. In terms of past medical or surgical history, it's important to know about previous migraines for the reason I've just mentioned, previous bleeds, hemorrhages in the head, and previous cancers as well. In terms of medication history, it's important to inquire about overuse of headache medication or analgesia for medication overuse headache, the use of blood thinners like warfarin as well for bleed risk, and things like allergies as well. In terms of family history, it's important to know about history of migraines as well in the family or malignancy. In terms of social history, it's important to cover things like smoking, alcohol, drug use, because the headache could be related to either the usage of those or withdrawal. You also want to gain some insight about the effect that the headache's having on their quality of life, on their job, on their home. Do they have any job or home stress that might be precipitating the headache? And lastly, if it's sort of the appropriate clinical context and time, you do a systems review, which helps pick up any symptoms not initially said by the patient. So we'll talk in more detail about how to examine and assess patients for specific pathologies later in this talk, but as a sort of general overview, after taking your history and sort of assessing for red flags, if they're a trauma patient, for example, they'll need a full ABCD assessment, and that includes your usual ABCDE, but including things like high flow oxygen if they need it. Important thing to be aware of is cervical spine stabilization as well, any intubation or ventilation if they need it, or any urgent referrals to neurosurgery after that point. The baseline bloods to be aware of are your FBC for blood count, urea and electrolytes, liver function tests, CRP and ESR for inflammation, glucose to see if it's part of a hyper or hypoglycemic episode, and a CT head is important for suspected or reported injuries or bleeds, and especially important as well if you want to do a lumbar puncture. So moving on to primary headaches. So this is a sort of summary table about the three main primary headaches worth knowing about. We'll just go through each one in turn, and starting with tension headache. So this is a headache that's classically bilateral, but it can be variable. It's a dull pain, usually a band-like a pain around the head, often linked to things like not drinking enough water, being stressed at home, which may roll over and affect your sleep. So you have poor sleep, too much caffeine, living with chronic pain, agitation. These all cause tension headache, which is worth inquiring about in the history. Even though it's linked to these things that often do affect your activities of daily living, the headache itself actually doesn't sort of stop you doing any activities you need to. There usually aren't any other associated symptoms to do with the headache, and the duration can be variable. In terms of migraines, this is slightly different. The pain can be in different areas of the head, but it's often a throbbing pain, sort of pulsation that you feel, often more severe, so much so that you can't do your usual daily activities around the house. People often feel they have to go into a dark room, close their eyes. It's linked to triggers often known by the patient after a certain time, things like poor sleep, caffeine, linked to menstruation as well, certain foods. The thing about migraines as well to be aware of is the aura, which can happen before. So this is a sort of warning that patients seem to get before they get a migraine. Not everyone has it. Some people do, some people don't, but it often lasts around an hour, and can include some sort of seeing blurred lines or disturbed taste or tunnel vision as well. In addition, the associated symptoms linked to migraine when you're actually having the migraine is a photophobia, sensitivity to light, or phonophobia, sensitivity to sound, nausea and vomiting as well. And usually, classically, this lasts between 4 and 72 hours, but again, it can vary. Lastly, for cluster headaches, the etiology and causes aren't really understood fully, but it's linked to smoking and alcohol use and previous trauma as well. The pain's often around the eye or above the eye. It's linked to having red eye, watery eyes, nasal stuffiness, congestion, swollen eyelids as well. People can describe it as a sharp pain, but the character is variable, and it's severe. Again, like migraines, so patients often can't do their normal activities around the house. Again, it's variable, but classically lasts between 15 and 180 minutes.
So, as well as those features, a really good acronym to use to remember migraine triggers is the word chocolates, because then you can see that stands for chocolate or cheese, the oral contraceptive pill, which is a big contraindication if someone suffers with migraine with aura, for not having the contraceptive pill. And then also includes caffeine, certain odors and smells, lack of sleep and extreme tiredness, alcohol, travel, specifically like loads of air travel, changing time zones a lot, exercise, and for some stress as well.
In terms of managing these primary headaches, there's some specific things for each one. So starting with tension headache, an important first step is to identify and manage any of those precipitating factors, things like your stress or mood disorders, any chronic pain, dehydration. These things need their own specific management because that in itself might remove the tension headache. In addition, you can try just some simple analgesia, things like paracetamol, NSAIDs, or aspirin. Obviously, with prolonged use of NSAIDs, you'd need to consider going gastric protection with PPIs. For migraines, you can do everything I've just said, plus specifically trying oral triptans and antiemetics for nausea and vomiting, and then following up that patient in the next month or so, couple of months. Another thing with migraines that's important is to realize what the triggers are, even though that's more of a preventative measure as well. And for cluster headaches, this requires a referral to neurology. In the acute setting, it needs a subcutaneous or nasal triptan with short burst 100% oxygen therapy via a non-rebreather face mask. So in terms of preventing these headaches, these are some measures the patient might want to try if the sort of initial treatment isn't working. So for tension headaches, if things like simple analgesia isn't helping, you can try acupuncture over a couple of months. In addition, low-dose amitriptyline can be tried, along with certain relaxation techniques as well. For migraine, you can do the things you can do for tension as well, plus getting to know your triggers, like I said earlier, knowing what precipitates a migraine specifically for you. And more specific prophylactic medication for migraines includes firstly trying propranolol, then trying topiramate, and then as a third line measure trying amitriptyline. For cluster headache, because of the direct link with smoking and alcohol use, it's important to be cautious with that. You don't necessarily need to stop, but definitely be aware that that could be precipitating the headache. And in addition, trying verapamil, which is a calcium channel blocker, and a short course of prednisolone as well. So this is the end of the first part of the talk. Second part will be about some other causes, including medication overuse headache, hemorrhage, and giant cell arteritis, and a brief bit about meningitis as well.